James Davis.
Thank you, Chair. Professor McGorry, we've already heard today about the problems of waiting times, particularly in this country for CAM services. But in my experience as a GP, it's also rejected referrals. So access to services is a real issue. In terms of early intervention in mental health issues in children, can you emphasise how important that is and actually the financial benefits that can accrue as well on a national scale?
Yeah, thank you so much. Well, I think it was I can't remember whether it was Lucas or Hope talked about in the personal sense, but we've got extremely good data from particular illnesses, particularly psychotic illnesses, and this goes back, as I said earlier, to research that began in the 1990s, where the delay in treatment is absolutely it absolutely determines the level of functional recovery that's possible from an illness like schizophrenia or some other psychotic illness. And if you get there's a term called duration of untreated psychosis, which the UK government actually a few years ago did actually bring in a target that you had to actually treat psychosis once it was recognised within, I think it was either 2 weeks or 4 weeks. I think Jeremy might know the answer to that.
2 weeks.
2 weeks, yeah, which actually dealt with something which probably could have been realised back even 10 years earlier, that you had to make special efforts to reduce that DUP, because the evidence is really clear. From American research, we know that the early intervention services, like these early psychosis services that are still, I think, in most parts of England, they don't work if the DUP is longer than a certain period. So they don't work any better than standard care, but they work much better if you get the person earlier in the course of the psychosis. Now, that would be also true for anorexia. I think with Hope's case, we haven't got the data to show it, but it's the same type of illness with potentially serious, potentially fatal, potentially very disabling. I think they all fall into this sort of pattern, but we haven't got, I suppose, specific evidence for every single condition yet. But we've got it from probably one of the most serious sets of illnesses, and the outcome is so much better than people think. You know, the pessimism that's entrenched in psychiatry has to be swept away, but you can see why it isn't, because substandard care is mostly what people get. So it reinforces the clinician's illusion that the outcomes are poor. But I can totally relate to your frustration as a GP trying to get people into these very tightly managed and gate-kept services, because I spent half the week myself this week working in Headspace, trying to get people into the specialist services, even as a psychiatrist, trying to get them into the more specialised services, because they're still under-resourced. That second tier of care is still under-resourced. And it's absolutely devastating for, as I think Cassandra was saying, for the young people. They put their hands up, they've tried to get help, they're told, you know, that it's amazingly invalidating to be told that, and it's intensely frustrating. It causes a moral injury in the practitioners as well, I think. They can't actually do what they know they should do. And other doctors don't have that problem. In cardiovascular and cancer medicine, you don't have that moral injury, but in mental health, you do, because you cannot do what you know is needed for the patient.
Mm-hmm. And just one further question in terms of the setup of the Headspace network. You said it's funded by the federal government in Australia as a primary care service. Is it a top-down approach, or do you allow local areas to model the centre according to local need and makeup in terms of the clinicians there?
That's a fabulous question. And yes, it was top-down. It was centrally commissioned for the first 10 years or so. And I've been on the board ever since it was set up, and the central commissioning worked very well to make sure you had the same quality of service as best you could across the whole country, and the same brand, which is incredibly important for young people, the trusted brand. I think Cassandra was referring to this too. And it did allow local tailoring, because local consortia had to bid for the right to run the service. So it did actually, it was locally led, locally run, but it was franchised, I suppose you could almost say. But then, you know, about 3 or 4 years ago, the government, in its wisdom, decided to devolve the commissioning to 31 local commissioning agents or primary health networks, which put the whole thing at risk. But it was under this kind of philosophy, we must have local tailoring of services, which was already the case. But it was like a political correctness that suddenly crept in and put the whole thing at risk. Now, we've managed to kind of protect it, but it's taken a lot more effort to do that, and I think it's a very unwise model, this devolved commissioning model, which I know you have in the UK or you have had, but it's a smaller country, so maybe it's a bit more feasible. I'm not
we
sure,
have
but
many debates on that, Pat. Yes, indeed. Let me bring in Cassandra.
Thank you. I think it's really important to emphasise, it's great to learn from what's been happening in Australia, that we have services here that have, huge expertise and insight into their local communities, and have also built trust with those communities, sometimes over decades. I think, what's really needed is to ensure that they're properly funded, there's accountability for that happening, that they have a seat strategically in shaping what happens in their local areas. And I think one of the reasons that they are so successful in working with young people is that they aren't seen as kind of establishment or the same as traditional routes. They work because they're very young person centered, and they bring together the kind of that skill of youth work with expertise in advice and kind of therapeutic and counselling expertise. So I think it's really about, recognising and building on that fantastic resource that we already have in this country, but enabling those people to be able to do their jobs.
Could I just quickly say I agree with everything you just said, and I think you can get those outcomes and that local ownership still with a central commissioning model, as long as the services are locally run and adapted.
Thank you.
Absolutely.